again, everybody. Welcome to our second series of Health and Science Made Simple. We'll see about that. I don't know anything simple about neuroscience, but our expert panelists today are experts in all of that. For those of you who don't know me, my name is Maria Contreras. I'm the Executive Director here at the Masonic Medical Research Institute. I'm also a scientist, a professor, and my research is focusing on some neurocognitive diseases. We study autism. We're moving into Alzheimer's and Parkinson's, and we're interested in PTSD. And my colleague, Dr. Chase Kessinger, who's in the background here, and I are working on a project specifically for PTSD currently. So I know that's an area of active research for a lot of people and an interest for a lot of people. So MMRI, for those of you who may not know anything about us, we've been here since 1958. Our research has primarily been focusing on cardiovascular research and diabetes and obesity, but we have expanded into these other areas, which now include neurocognitive and autoimmune diseases. So if you have any questions or you need information, I'm sure there are many of us in the hallways that will accost you on your way out to be able to see a little bit about MMRI. But I'm delighted today to introduce our expert panelists. I'll start here to my left. Dr. Julene Kinda is a highly skilled emergency medicine physician and a regional leader in neuromuscular and neurological care. She's known for building innovative systems that connect patients to the right specialists quickly and efficiently. As stroke director at Rome Health and a key clinical leader with CNY brain and spine neurosurgery, she's helped develop a model that streamlines urgent evaluation, triage, and referral for spine, neurologic, and orthopedic conditions. She also serves as the health and medical editor for Mohawk Valley Living magazine and as an on-air correspondent, helping bring trusted medical insight and education to our community. Through both her clinical leadership and public engagement, Dr. Kinda continues to advance a more connected, patient-centered approach to care across New York, central New York. So please join me in welcoming Dr. Julene Kinda. Next, we have Dr. Nicholas Kinda. I know Nicholas. He's a board-certified neurosurgeon and the founder of CNY Brain and Spine Neurosurgery, where he leads a comprehensive program focused on complex brain and spine care across the Mohawk Valley. I have had the pleasure of being in his office. It is people waiting outside. You would think it was a really amazing place that people desperately want to get into, but to see Dr. Kinda, he's an incredible scientist and neuroscientist, so I'm really grateful he's in our community. He specializes in minimally invasive deformity spine surgery, as well as advanced cranial and neurological conditions. And he's been instrumental in advancing surgical techniques and technology together throughout the region. His work focuses on improving precision, outcomes, and access to high-level neurosurgical care locally. And in addition to his clinical work, he's actively involved in collaborations for research, medical education, and regional healthcare development. He serves as a clinical leader, educator, and advocate for brain health, stroke awareness, and innovation in neuroscience. And beyond medicine, he's deeply engaged in our community with initiatives that work closely with organizations such as the Community Foundation and expands care to support the next generation of healthcare leaders. Please join me in welcoming Dr. Nick Kinda.
Thanks, Carrie. I got to get a copy of that.
And finally, I'd like to introduce Dr. Satish Krishnamurthy. I hope I pronounced that pretty well. He's a nationally respected board-certified neurosurgeon, professor of neurosurgery and biology at SUNY Polytechnic in Utica. He's also a practicing neurosurgeon at CNY Brain and Spine Neurosurgery in New Hartford, and he's held key leadership roles, including the chair of the Department of Neurosurgery and Medical Executive Committee at SUNY Upstate, and he's contributed nationally as the chair of the Communications and Educations Committee at CSNS. A federally funded and internationally recognized researcher in hydrocephalus, which is a large brain, for those that you don't know, like the fluid in the brain. Dr. Krishnamurthy continues to advance innovation, quality, and patient-centered outcomes while maintaining a strong commitment to safety and excellence in care. Please join me in welcoming Dr. Satish Krishnamurthy. Thank you. All right, so we're ready to get started. So today's information session is going to be about neurocognitive health and science. And I'd like to start, and this is an open forum, so I hope that you will all think about asking questions along the way. But I'd like to start by asking Dr. Jolene Kinda, what are the biggest common risk factors for things like stroke and dementia that people may not even realize they might be at risk for developing?
I think that's a great way to start off because it all starts there, right? So, really, a lot of these neurological disorders like dementia, stroke, a lot of other cardiovascular disease all stems from our vascular health, basically the health of our blood vessels in our body. And we know that the major risk factor for stroke is high blood pressure. And the problem with high blood pressure is we call it the silent killer because you don't feel anything. You have no idea if it's high. Now, I do have some patients who tell me, I know when it's high, I can feel it high, I feel it whooshing in my head, but we have no way of like actually objectively, measuring that like sort of sensation that people have. But people don't know if they don't have their blood pressure checked like at least annually or at a regular doctor's appointment, they have no idea if they have high blood pressure. And so many times I see patients come into the ER and their blood pressure is over 200 and they had no idea. And that just breaks my heart because for probably years, their blood pressure has been damaging the blood vessels inside their body, not just their brain, but also all over. So really high blood pressure is the main one. Of course, there's many others, high cholesterol, smoking, all kinds of things, but I think they wanted to say something.
So it's hard being married to a very good doctor because then, but I have a question, Dr. Khan. So, and Dr. Krishna. So everyone says, oh my God, blood pressure, blood pressure. But I bet you if I put a lot of you in some stressful situations, all your blood pressure would be high. I just may have a lot more stressful situations than some of you, and some people want my blood pressure checked often. But how do you get an accurate blood pressure? How do they get an accurate blood pressure? How do we get our resting blood pressure? I would rather someone just take it like an Apple Watch can take it while I'm sleeping or something. I mean, I don't know. Resting blood pressure versus, if you're running 20 miles, how big? So temporally, what is the blood pressure? What if you have a high stress? What if you're a military guy and you're always doing war games and stuff like that? And I don't know, or a neurosurgeon who's really busy.
So it's a very good question. There's certain ways to take blood pressures. And we know that certain ways of taking blood pressures that will give you an inaccurate reading. So like in the ER, if we have too small of a cuff on their arm, that will give them an inaccurate reading.
What about white coats?
Well, it was interesting that you bring that up because we know that patients who get white coat syndrome and their blood pressure is able to fluctuate to a very high blood pressure in just the presence of a white coat, that those patients are more likely than non-hypertensive patients to go on to actually have a diagnosis of high blood pressure very soon, within a few years of that white coat syndrome, even if it goes back down to normal, which is, anyone know what normal blood pressure is? So, I mean, generally, for just to simplify things, 120/80. And the guidelines for blood pressure have gotten tighter and tighter and tighter over the last few years. So there are right ways to take it, wrong ways to take it. You really need to take if it's an automatic cuff, you have to take it into your primary care doctor to get calibrated to match their levels. Of course, manually taking it is probably the most accurate one, but we know that blood pressure fluctuates throughout the day. And one other thing I see all the time in the ER, and I know Satish has something to say about this too, but some other things I see is patients come in all the time to the ER just because their blood pressure is a little bit high. And they say, but it's 160 and I normally run at 140. And I said, it's okay. What we care about is the average blood pressure over decades, right? So like now, if it's 260, that's a problem. But like, high 100s in a stressful situation or someone who's been under a lot of, work related problems or whatnot, it's going to fluctuate. And we know blood pressure is going to be highest first thing in the morning because that's when our adrenal glands wake us up and release our epinephrine. And so patients who measure it first thing in the morning, but before they take their blood pressure medicine, they're going to have a high blood pressure. So I tell them, don't take it and don't obsessively take it. And the more you measure it at home, the worse it's going to get. It's going to go higher, and then you're going to get more stress, and then it's go higher. It's just a vicious cycle. So try not to check it too much. Follow up with your regular doctor and make those adjustments to get tighter blood pressure control, because we know that's the major risk factor for a stroke as well as other. So I know that was long-winded. Satish, Nick?
No, I completely agree with both of your statements. And I want to just reiterate that to take the correct way of blood pressure measurement is you can use, you can go to the American Heart website, which is heart.org, and they have on their website, they have listed how to take the blood pressure. You have to be sitting for 2 minutes. You got to have the cuff at the level of the heart. You can't cross your leg, and you should be not taking at certain times after eating food, et cetera, et cetera, et cetera. But stroke risk factors, there is diabetes, which is sometimes linked to obesity and sometimes not linked to obesity. There are people who have abnormal ways of metabolizing their sugars, and they develop insulin resistance, and some people have insulin antibodies, and you won't know all of this. There are different kinds of diabetes, and you should always look for changes in your glucose metabolism, because all these changes in the chemistry will make your blood vessels narrower by putting plaque on. And when you build on the plaque and then you have high blood pressure, which puts a strain on your heart, whatever affects the heart will also affect the brain. And the risk factors for heart attack are the same as risk factors for stroke.
Yeah, I agree. So, these two are really smart. I gotta kind of dumb it down for myself, because I think Satish did it perfectly and Julene did, but let's break it down. Obesity is huge, right? So why do obese people get high blood pressure? Anybody in the crowd know? Anybody? No? Anyone got an idea or thought? So, ideal body habitus, right? Ideal weights and size of your body. Your heart has is pumping blood, right? And it's pumping it against and trying to get it to the ideal areas. Just out of curiosity, what's the most ideal area? I know I'm cheating a little here. What's one of the most ideal areas, right? Two of them, the adrenal cortex and then the brain, right? So you got to get enough blood up into the brain. And so your body will fight to pump blood to the most particular areas. Unfortunately, if you have more size to you, you have to push harder to get the blood to the locations that are at. Diabetes, probably one of the huge things, and it's something that we all don't want to get. You end up having what Satish was talking about, vessel damage, endothelial damage to the blood vessel linings, which make it more of an inflammatory area, that the deposits of cholesterol and thickening of the blood and causing more reaction to that area creates what we call a thrombus, right? And that thrombus can either block off the vessel, or if you have high blood pressure, kick a clot out and cause yourself a stroke a different way. So we see it all different ways. We have to discuss this, because until you put it in front of your face, you're not going to take it seriously, right? But what are the numbers, Julie? Seriously, what are the numbers out there with stroke above the age of 40, obesity numbers? Our country has a major problem, right? Right now, we are heading down wrong roads, and that's why GLPs are so important, right? And Maria does the research on the GLPs, and we're trying to get weight down, but we don't want to do it entirely artificially. We want to do it the right ways, but we got to get back ahead, whether it's food source and everything else. Lena, we talked about increasing and making better food choices. And I'm going to just digress here for 2 seconds. The food choices in a school, at least I saw on social media on one of my kids' phones that were on there, the food choices in Europe, Italy, France versus the chicken nuggets and mac and cheese here. I mean, it's disgusting. And the failures of countries are based on how we educate and support health in our youth. All right, I'm going to drop the mic on that one.
That's very nice. And I love that we brought this back to the cardiovascular health, given that that's our history here at MMRI. But it is true, and we've been studying as well this link between the brain and the heart and how important that communication has been. And also the microbiome, to your point about what we eat. Everything that goes in our gut actually travels and controls our brain health and our cardiovascular health. So that brings me to my next question, and I'm going to direct this to you, Nick. What are the classical signs for someone who might be developing things like dementia or Alzheimer's? Because hypertension is really important in stroke. But is it stroke symptoms or hypertension and or cardiovascular, obesity, diabetes, all those things that lead to dementia and Alzheimer's? Are they different?
So this kind of hits home for me. I'll give you a quick story. It's always good to lend a story, personal story to situations like this. And I'm going to start out by saying that you're given. I always said this to everyone. They're like, "Oh, Doc, why don't you come for a 20-mile run?" And my wife knows I ran when I was younger, but my kids don't think I know how to run. I say I got 2 knees and 2 hips, and I'll play basketball and with my kids and mess around, but I'm not running anymore because I don't want to go get replacements. I say that for every part of your body, right? You only get one heart, use it and protect it to the best. You only get one brain. And this is something that's very dear, I know, to Satish and to me, is protecting brain function for as long as possible. Because as you look at what we would consider fairly benign brain MRIs, we start to see these T2 signals that we wouldn't expect in many people. And you start questioning, okay, it's microvascular disease and this type of thing. But one day, this is the story, I get a phone call from my mom that says, "I don't want you to worry." And of course, that's usually the first statement. But your dad had a seizure and he's at the hospital. And I'm a neurosurgeon, right? So you hear that, and Satish can agree with me. The first thing you think is he's got a brain tumor. So I literally call one of my friends, and he gets me on a plane, and I get to Michigan. Actually, call one of my friends. He got me a plane. My wife said, "You're not flying private." She booked me a plane ticket and got me to Michigan pretty quick. So I got there and I found out that my dad had been, we knew that he snored. It was kind of funny. His snoring was kind of, "Oh, your dad snores." And then we found out that this obstruction kindled his brain. And one of your most sensitive areas is a part of your brain, and the medial portion of your temporal lobe and your hippocampal area, and amygdala, and this is a sensitivity for having seizures. That's really, quick statement of you lack oxygen at night, you decrease. It's actually one of the we used to induce this in rats to kindle their brain, to stimulate, to have them to have seizures so we can treat them. And literally, this was happening to my father. If you don't think you're a shoemaker whose son doesn't have any shoes, that's how I felt. So brain tissue dies from little things throughout your life that you're not even paying attention to. Whether it's alcohol, we know that a significant amount of alcohol does it. Lack of good oxygenation. We talk about, and I think Satish does all this stuff, or his wife makes him, He does deep breathing and or your daughter, right? Your daughter gets you to do all that. Your grandson now. So deep breathing, we see these people saying, oh, do you meditate and deep breathe? It's really about taking in oxygen, maximizing FiO2, the functional contained capacity of your oxygen, and really, really trying to make sure you oxygenate and blood pressure control and all these things. You have to protect every part of that brain. And I know I digressed here, but the brain will break down and have degeneration, just like knees, just like hearts, just like lungs, if you don't take care of them. And it's the most important. And I know it's not technically a muscle, but to me it is a muscle. It's the most important muscle in your body. All right, I think I went on. You want to go?
Thanks. Well, I'm just going to add to that before you answer, because, you talk about the brain like a muscle, like you have to exercise it. So I do crossword puzzles. That's my thing. But the question to elaborate on that point is, what do you do to protect that brain? What do you do to actually prolong getting dementia? I mean, eventually, I think everyone in your 90s, you're going to have some dementia. How do you protect your brain, and what should we be looking for signs if we're developing something that's worrisome?
So that story is very impressive in the sense that it goes to show that how every one of us is vulnerable, and brain is the crown jewel of evolution, as one of my professors put it, and we need to protect it. The problem comes when we all forget to do this thing, and we all have had the experience going to a room and saying, what am I doing here? So that's not dementia. So you can't get alarmed with all of that. The dementia starts when you have problems with executing a task. You don't know how to put on a shirt. You cannot make eggs on a stove. You cannot understand what to do in the morning with the morning ritual that you're used to so many days. You can't find your bathroom. Those kind of things are really important signs of brain dysfunction. And a few risk factors exist. Head injuries, no matter how much mild it is, can damage your brain, and this damage is additive, and it can, over a period of time, it can tip your brain function to a point where you can no longer function normally in a cognitively useful manner. The other thing that is very common is hearing loss. As we age, we have problems with hearing, and most people say, I heard you just fine. Just leave me alone. Why are you bothering me? I don't need a hearing aid. It's so ugly. That's important.
Sensory input.
Sensory inputs, whether it's vision or hearing.
Smell.
I saw that in my father-in-law, and it took me years to convince him to wear the hearing aids. And the cognitive dysfunction had already set in because he was locked in his own headspace, and it was not very easy to get out and think. And as you mentioned, Nick, the alcohol is a very bad thing. And everybody says, oh, a glass of wine is good for your heart, but it's terrible for your brain. It's neurotoxic. It kills your cells. It makes you dysfunctional. It kills your cerebellum, which is the balance organ that helps you keep the balance. You trip and fall. And when you get old, you fall. It's the third leading cause of death. And there are other things like strokes. Like there was a good study that was done in Pittsburgh where they looked at the link between the cardiac health and brain health. And this person studied thousands of patients for over 15 years. And people who had heart problems also had brain problems. So they're linked. Yes, sir.
So I think you started to answer this question for me. I was trying to think about what is different in this equation for, say, an 85-year-old versus a 50-year-old. So I wouldn't have thought about sort of the hearing as a driver. I assume that certain things about, staying active, keeping your various tests within normal sort of apply to the whole population. But what's different for someone who's 85 years old in terms of trying to keep them functioning?
85-year-old is already advantaged, right? So you must have good biology to keep you alive at 85. So you probably have good cardiac health. If you're looking at cognitive dysfunction at the age of 50, you probably have had multiple risk factors or multiple injuries or multiple strokes that have led you to consider, oh my God, am I getting demented? So it's ultimately the amount of brain that is left that can actually function for you. So 85-year-old, the only thing that keeps your brain active and the one intervention that keeps your brain healthy and active is music. If you do fMRI, it lights up the entire brain. Music and dance.
Megan, functional MRI studies, it increases significantly. I'll ask Julene and Maria if you can come on this. Here I go on my social level, right, on a societal issue, but this really bugs me about what I've seen in other countries and what we do here. You turn the age of 65, right? So somebody said to me, oh, Social Security isn't going to be there. I was like, good. I think Social Security, or this idea, it made sense when we were in an industrial country and we were working on the lines at Ford and we were doing even to some extent farm work. But retiring shouldn't happen ever. By the way, you never retire, right?
I think that's an interesting point, actually.
Way too early, 65.
Yes.
You have to stay functional. And we're seeing this, and I don't even care what the job or social interaction is, but it's terrible what I'm seeing happening. And some of my best advice and best help I give my patients, what are you doing? No, get out, get with your friends. So please continue.
In Greece, I can tell you, people retire not by age. If they work 20 years, they get a full pension. So my cousins were retired before I got my job. So I started working after school. I was 35. My cousins were retiring. But the difference in Europe versus the United States is that when you retire, your life begins. They're very social. They interact with people. They go out. They dance. They sing. They party. Not with alcohol, some alcohol, but not to the extent of alcohol. What's that?
Usual.
Ouzo, yes, it's better to drink ouzo. But people actually have a social life. And here in the United States, I see it in my in-laws, they become really introspective and non-social. And I think that has hurt their mental capacity. Mm-hmm. And I want to come back just for a second before I go to Julene, but you brought up the losing ear or hearing as part of that. I think that's in part losing the social ability that people have when they retire. But is it the cause or the effect is my question. Do you lose your hearing in part because you're predisposed to getting dementia, or do you become, neurocognitively impaired because you're losing your hearing? Which way is it the chicken or the egg?
I think you lose hearing before you get incapacitated cognitively. We see this in children. We see this in children. Exactly. We see this in children, right? There is in patients with cerebral palsy, they're not functioning well. The interventions that help are checking the vision, checking the hearing, and fixing those. And people actually start getting much better.
Oh, that's interesting.
So I think it is.
Julene will agree with you. Tell them oh my gosh, you do not want to not have your hearing aid on in front of Julene.
No, I think, and I just want to make one point too, is this whole metabolic syndrome Yes, males are more predisposed to losing their hearing as they age than women, right? But also, I think males probably in general snore more. And we know that snoring and sleep apnea literally damages your hearing cells. And that is a major contributor to, especially untreated sleep apnea and snoring, contributor to hearing loss, which then, besides having metabolic syndrome in all of those comorbidities, that in and of itself, combined with everything, leads to more advanced neurocognitive decline faster. And exactly what these guys said, like the less sensory input you're getting, the worse brain function you're going to get. And then you retire, and then you're dwindling even more. And then our geographical living situation of, suburbia is not conducive to visiting every single night with neighbors and friends and going out and doing all these things that you're saying. And then we end up with our elders being isolated, alone, lonely, not doing anything. And then cognitively, they just.
Well, in the 80s or 90s, hard rock was very loud, and we didn't know that it hurt the hearing as much. Right, Alex? I mean, we just listened to it loud. That was, nobody agrees, okay.
Thank you.
So 2 factors that I wanted to ask about for dementia: heredity.
Yes.
And the next one, and I don't know if I literally created this, but I tell people, so I think I read it somewhere. If you go under anesthesia, general anesthesia after a certain age, does that have an impact on the onset of dementia? I know with both of my in-laws, mother-in-law and father-in-law, it was shortly after they went under general anesthesia for surgery that dementia onset was very quick and very rapid. So I wonder if there actually is a study. I feel like I read something in the New York Times like 15 years ago, but I might have made that up. I've just heard these guys.
So I'll start, and then you can give them the real answers. So, so number one, I think everyone, doctors are really good at, and research scientists are really good at trying to name something, right? And so if we can see a particular location of the brain that degenerates, and then we can take that brain, slice it up, stain it, and get some particular bodies or stains that are positive. We can start defining those bodies based on who figured it out. Louis, Hirano, all these different cute little names. But at the end of the day, we're talking about degenerative process in different nuclei throughout the brain. And as Dr. Krishnamurthy explains, the final frontier of our evolution is our brain. Actually, most of the people today would argue that it's not, it's the gut. We're going to hold to the brain for as long as possible.
Or heart.
Yeah. Well, so that's number one. Number two, there's different types, and there are some that are more prone. What you're going to find, and I'll have you answer this, is that pretty soon anything that is genetically linked or has an associated a location, chromosomal allele location that has value to or put you at more prone at risk, which likely will be correlated to social habits or exposure, will put you at higher risk, are going to have some linkage, right? And so that's why we see patients who have Parkinson's, they may have a genetic piece and an environmental or non-environmental factor that correlate, putting you at earlier risk for certain types, right? We see that the same way with some MS patients, which is not necessarily linked in the same way, but is a degenerative process. So that was question one. Question two was the anesthesia, without a doubt. Now, the question is the induction process of anesthesia and the drugs that are used, I think they're starting to see more definitive correlates to it. But people who undergo anesthesia, it has a significant effect on them, not just for days, some for weeks, and clearance of those types of drugs inside their bodies and such. So I tell patients sometimes when they're older and they're like, is there a risk? And I say, there is a risk and there is some issues. Some of that could be early hypotension in the process. Some could be just the drug-drug interactions that they have and undergoing anesthesia for a certain amount of time. But there is an effect on that, especially in older people.
Yeah, I agree with the last part that he commented on. There are many drugs that impair your cognition. There are many drugs have been associated with poor cognitive performance. For example, beta blockers are worse than calcium channel blockers in people with cognitive impairment. The second thing is blood pressure changes, especially too much control, is worse than not taking medication. Higher blood pressure in somebody who's 80 or something like that is actually desirable because the blood vessels are already narrowed, no matter how good you are in taking your medications, and you need enough blood flow to the brain. And so you drop the blood pressure down even further, it'll cause you more damage. Regarding the first question, there are conditions like Down syndrome that put you at a higher risk for getting Alzheimer's dementia. There is a small but a definite risk of inheriting dementia from your family history, and that's always there. But most of the dementia we see are acquired and probably prevented.
We need to talk about sleep.
Yes, I was just going to ask Julene about
Please.
that. So I think I know I just got back from Taiwan, so I don't know what day this is. And I can tell you the lack of sleep makes you crazy. But some people, myself included, have a natural sleep cycle that's like 6 hours. And of course, I've been reading in New York Times how awful that is, because you're predisposed to developing all these neurocognitive insufficiencies. And I foresee this happening. I forget all the time things. But tell us about how important sleep is. And then the other question with that is, because women, I think, sleep a little less than men, what are the sex differences in developing neurocognitive dysfunctions?
I think those are really good questions. So we all know that sleep or lack thereof, or chronic sleep deprivation, like raises your cortisol levels, which raises your blood sugar, which raises your blood pressure, which makes you more hungry, which makes you eat more. And then it's just a vicious cycle on and on. We do know that women in general need more sleep than men. I'm one of those people that I need a minimum of 7-8 hours. He can survive, I don't know how, but he does it. He's like you on 5 or 6 hours and be highly functioning. But we know that people who sleep better and have a good sleep hygiene routine, a cool room, a warm blanket, lights out, blue light, all those things to help them, their brain is going to release melatonin better, and melatonin does get decreased with age. So as we age, your pineal gland will release less and less melatonin. So we know that folks, older folks, they may go to bed early, but then they're up way early. Like my parents, they're up at 2, 3, 4, 5, and these were people who used to sleep 8 hours a night. So, but they, trying to get that good night's sleep, and I think it's also, what you do during the day. If you're 7 years old and you walk 5 miles during the day, and then you go hang out, have dinner with friends or your grandkids or something, you're going to get a better night's sleep if you're versus if you're sitting around all day. So, so those things are important. Sleep hygiene, getting good night's sleep so that you're metabolically on a better page. And what was the last part of your question, Maria?
Just the sex differences between men and women in developing neurocognitive disease.
I'm going to defer to these guys for that. I don't know specific statistics off the top of my head as far as exact percentages of women versus men, but I think a lot of it is what we talked about with social isolation and things like that, and then comorbidities.
So I got to tell you, I think that everybody's looking. We improve our longevity but I don't think we improve our overall health status,
Our
right?
mortality.
Yeah.
Yeah.
So, one of my friends is building this health clinic in Vegas, and we all see it, right? You want a cold plunge, you want a sauna, you want to learn to deep breathe, you want to take every single thing, NAD from the Harvard guy that, and my wife will laugh.
Sinclair.
All these
It doesn't absorb.
yeah. So, or get the injection, or take it with some yogurt and some fat, and all these things. But I think it's saying something, right? Number one, out of all those things, what do you think the data showed was the best thing for longevity and health? Exercise. Period. Nothing beat exercise. Number two, sleep. Exercise, sleep. Number three, a balanced vegetable Mediterranean based diet. Right?
Three strikes for me.
We didn't even talk about the
Three strikes.
new cholesterol guidelines that just came out 3 days ago.
Yes.
Very interesting.
So the food, the pyramid is
Mhm.
upside down now. So that's been a huge change in terms of how we're supposed to be eating. Although, thanks to RFK, we're supposed to still be eating a lot of red meat, but we know that that's also not super great for you as well. But other questions in the audience that we could talk about?
Please, we want to hear from you.
Yeah, this is it has to be
That
a
was really
social
good. The
interaction.
anesthesia one.
Often do you have
I
a
had no
really
idea.
pretty smart woman?
We have a question in the back here.
Stand up and say your name and how you heard about this place, and ask some questions.
Hi, my name is Ahmed. I heard about this place from Zach.
All right.
Awesome.
I'm with the Young Professionals Catalyst Group. One thing that I'm very curious about is that you stated that underactivity of the brain is the leading cause of dementia. Not enough blood flow, not enough nutrients to supply the cells. What I'm curious about is what's more relevant today is we tend to be more overstimulated through social media, constantly getting those dopamine hits. I wonder what that looks like under the fMRI, but that overstimulation, I know it has an effect on the prefrontal cortex, challenges with executive functioning, but how could that impact in those neurodegenerative diseases?
You're the experimental group.
So you're basically talking about a dopamine burnout, right?
Exactly.
Overstim.
Yeah.
This is coming up more and more. So number one, I have to digress for a second. So if you look at the number of people that are taking stimulants like Adderall or similar type of products out there, versus ones that are being prescribed it or getting an amphetamine indirectly. I think that was well said, right? It's extensive, right? And let's not misunderstand. I know some very high functioning people that use Adderall. Whether or not we have the biochemistry appropriate for how we are troubleshooting a need from the brain function, right? Versus whether or not there is a burnout and effect from it. So we do know that as you get older, you may become less responsive to the Adderall. You may need to take more breaks. You may need to go off of it for a period of time or switch to a different type of drug. And then those individuals could be more prone to chemical disruption in the brain, leading to things like depression or other types of brain disease that come from a chemical imbalance, right? We talk about depression, but depression is in a spectrum of other types of disease processes that can develop from that. So now you're playing in what Satish was calling the final frontier, and that's why this becomes an issue. So is that adding to breakdown of the brain? Yeah, I think there are some components to it. I am not completely well read on the entire science behind it, but to some extent I am. I know that my wife has looked into it as well, and Satish, I'm sure, but this is on the forefront of my mind as well. I don't take Adderall, but I wouldn't mind trying to.
That would be a very, I don't.
Me on Adderall would be crazy, right? Right,
You-
Zach's over there, don't give it to him. Yeah, I drink enough coffee to balance that out.
To,
Neurogum, I have used Neurogum.
Does it work?
I don't know, Zach, does it work? Does it work?
have you guys tried it too?
I think it works. It works pretty well.
Okay.
Yeah, that,
Steph, does Neurogum work? Alex, no? Yeah, no? Luke?
caffeine gum. Each piece, I don't know if you guys have ever seen it on Amazon, each piece has like a cup of coffee in it.
But it breaks down the enamel in your teeth. It's
Sure,
really
it's
bad
not
for
good
you.
for you.
Really bad for you. You get rotten teeth out of it. Don't do it. Don't do it.
No, I think that's a fascinating question, actually, and that would be like a research question, like, because this generation like hasn't gotten to elderly stages yet, right? Like, so
So there's an
the social media
experimental
generation
group. Yeah.
and the video game generation, like, hasn't you like
Wearing
that's-
earbuds.
Exactly.
Yeah.
So, like, is there such a thing as dopamine burnout contributing to dementia? I don't know. I think that's the next research frontier.
Yeah. I mean, my guess would be that it's a lot like traumatic brain injury. And that people who are on their phones nonstop, listening to music all night long, and not really being present, I think we're going to start to see in the next decade or more some dysfunction associated with that kind of addiction. So we're all, addicted to our phones, and we're working experiments. So I guess we'll know if the office actually spills out into the parking lot, which it almost nearly does already.
Well, the inventors of, social media know what it does.
Has anyone seen these movies, The Social Dilemma and all these?
They know what it
So
is. They know it's
fascinating.
addictive. They know they are targeting us. And can you believe that?
Yeah,
So-
evolutionary like engineering
Yeah.
based off of like the hunter gathering.
So
You're
one thing I want to comment on is that is not just the dopamine hits, there is a consequence for all of this, social media scrolling or doom scrolling or whatever you want to call it, is that it crowds out any useful functioning or developing skills that you can use in real society. And that guaranteed is like a social isolation. And at the minimum, it changes your mind to be more focused on immediate need gratification instead of looking at longer term delayed strategy. Whether you look at it in kids, the marshmallow test, this was a test that was done with 2-year-olds or 3-year-olds in New Zealand, where they put a marshmallow in front of the kid in a closed TV situation. And they said, if you can eat the marshmallow now, or if you wait for 2 minutes, when I go and come back, you'll get 2. And kids who did not eat the marshmallow had better financial productivity, better academic productivity, and they were socially much more normal people, as opposed to people who ate the marshmallow were more
I think I ate the
inclined to getting
marshmallow.
into trouble. Sorry?
I think I ate the marshmallow.
No, you didn't.
So to follow up with that, then, to your point about brain activity being so important in prevention of dementia and so on, what do you think the AI technology is going to be doing to the world?
Terrible. I mean,
You guys say
I
it's
think terrible.
terrible.
I think
I
it's
disagree
good,
with you. I
though.
disagree
No,
with
but
you.
if you can learn to use it correctly, where it enhances your ability to go out and do different things, great.
That's I want you to.
You know,
So I'm going to answer that with a story. This is a great
Here we
story.
go.
A great story. So there was a professor called Lars Lexa. He's a cruddy old
Oh.
Swedish professor. And his claim to fame was this devising this method to give radiation to a spot in the brain to treat instead of 6 weeks. He wanted to give it one shot
Swedish
and
guy.
done. Swedish guy. So
You have to
Carolyn,
identify the type of person dealing with the Swedish guy.
yeah.
No,
Karolinska Institute.
Yes.
Yeah.
Excuse me, who's telling the story?
it's a good story.
Karolinska is where they give out the
Yeah.
Nobel Prize.
Yep.
Karolinska Institute, and they opened this new apparatus called the gamma knife radiosurgery apparatus. It's just a half a sphere. You got holes in it, 192 holes in it, and you know where the beams will go. If it is a half a sphere, it'll go to the center. Now, only thing that'll move is the patient's head that's fixed onto the table, and the table will move so that the spot will go to the place where the radiation is. And it's precise to less than 2 millimeters. So the opening ceremony is there, everybody is there, and journalists come, and this guy, a journalist asks, are you really thrilled that you have your machine open to public? And he says, yeah, I think it's very nice to have a tool that can actually help my patients. So you must be really, really happy that you've built a foolproof instrument. So the professor gets really red in his face. And he says, a fool with a tool is still a fool. So I think that applies for AI. It depends on how you use it. It's just a
Exactly.
tool.
Yeah. So for the young people in the audience, some of us, maybe not you guys, some of us are from the generation where there was no computer when we were growing up. Google was a thing of like,
One in the classroom.
yeah, there was
It
one in the class and it was let X equal 1 to 10. Like I did my own programming, but what didn't exist. And we also thought along the way, AI, like we do now for AI, that Google would change the way we think. My God, now you can look it all up. You don't have to go to the library. Now it's all, you're gonna be lazy.
Britannica and so.
Yes, yeah.
You know, I wanna give Dr. Krishnamurthy some kudos here because I'm not certain, and I know a lot of you know him and have worked with him before. So let's clarify. I was trained by a neurosurgeon, Dr. Gary Simmons, and he and Satish have known each other and served on many committees together. And I consider, and most people in the realm around Gary consider him one of the best surgeons of his generation. Yes, Luke, he's a Dartmouth grad like you, but Satish is probably one of the best surgeons, educators, and thinking minds in neurosurgery. And he and I have thought extensively. I pepper him with questions on his drive home every time. He usually gets close to his driveway. He says, Nick, I gotta go, and he's up on me. But how do we maintain, develop kids, right, as neurosurgeons with all the different changes that are going on and still create his generation of neurosurgeons? It's gone, right? The guy who can come in, Satish can come in, do a spinal tumor, do a brain tumor, do a vascular clip, can do this. And he taught my generation, and he knows when that's all gone, the next generation will be very different in the future. How do we keep that? How do we maintain that? And I think this is how we have to utilize technology to advance and still figure out a way to get our kids educated, whether that is in the operating suite or operating theater, if you would, whether it's in the emergency room, or whether it's getting our kids to get off their phones and go to the bar and have a conversation with a individual that they're interested in, not the other side. This is not happening anymore, right? We're texting each other. We're interacting that way. We need to put those phones down and sit down with a cup of coffee or a glass of wine and have conversations and encourage that.
No one.
Or else what? No one, sorry. Half class, right?
I'm going to sort of switch topics for a second and start thinking about your questions, audience. But this is for Jolene. I'm wondering on the other side of the token. Okay, so you have a patient who gets diagnosed with advanced Alzheimer's. What do you tell the caregiver, the loved one? What's the best way to handle that? Because we're all sort of approaching the age we go from taking care of kids to taking care of parents. And it's a little different because you can control your kids to some degree. It's hard to control parents. My father's 92 and I'm dealing with this at the moment. What do you tell the caregiver about the best way to handle this?
So it's a very good question. So if someone was in the emergency department and they already had advanced dementia, usually the caregiver will already know. But a lot of times patients do come in and the family says, well, they have some memory problems, and they already know where it's headed because they've noticed personality changes, behavioral changes, maybe disruption of their sleep pattern, which is also very common in dementia. Things like what Satish said, not being able to do simple tasks or wandering out and not knowing where they're going or driving. So most of the time they already know before I meet them if it's advanced. But I help them many times make the decisions of, and a lot of times I have to bring this up. How far do you want to go? So, I have patients that come in that maybe the family hasn't talked about, do they want a peg tube for feeding? Because they're getting to the point where, they're not eating correct me if I'm wrong, guys, but the course of dementia can be rapid or it can be slow over a decade.
It can vary. That's
Right.
why we encourage them to just have a good time and don't worry about your interactions because they'll forget about it later.
But those hard conversations need to be, if you do have a loved one that has dementia or early dementia and they're still with it enough to tell you what their wishes are, best time is to have that conversation now because the natural course of dementia is they're going to start wasting away, they're not going to eat, they don't have any appetite anymore, they don't sleep. There's plus or minus a significant amount of behavioral and psychotic changes that occur. Hallucinations, they go on schizophrenia medicines. We put them on medicines to help them sleep at night. They're in the ER and they're needing chemical sedation. And so there's a lot of things that arise like that are extremely difficult life decisions for family members to make. So if you do know someone who has cognitive, it's good to talk to them now about what they would want. How would they want the end of their life to look, and do they want to be bedridden with a G tube and being fed through a peg tube in their stomach and not being able to wipe themselves? Most people would say no. So that's a good question. They already see me, you're usually diagnosed, but sometimes, I sometimes they don't know and it's early or moderate. And I ask the patient, do you know what year it is? And then the family member next to them is completely shocked that they don't know the date, the year, because it's not something like you would ask your dad.
Right.
Oh, Dad, what month is it?
Yeah.
But if there's casual ways for you to start those conversations with older relatives that you think might be having a cognitive decline, you can do that and then take them to their PCP for a mini mental status exam. And that way, if there is a dementia-related brain process that they can go on Aricept or maybe a medicine that can help prolong the delay of the onset of the disease, maybe that's the best thing to do. If you guys have any.
Well, that was sort of the question I was going to follow up, because I think the question about early disease is really important, 50 versus 85. And the question is genetics, right? The genetics are probably the biggest besides traumatic injury, right? You would imagine you have early onset Alzheimer's is because you have some genetic predisposition. Are there any good drugs?
So I want to
And we have a
mention a
question
few
right here.
things. I want to mention a few things that are important in understanding dementia. The first thing is to make sure that you don't have a treatable form of dementia. There are some metabolic disorders, thyroid, low thyroid being a common problem. There are some B12 deficiencies, B6 and B12 deficiencies that look like dementia. There's normal pressure hydrocephalus, where you have fluid buildup in your brain that is treatable. You can recognize it, you can put a shunt in, and people get back their lives. There are tumors that can cause dementia-like syndromes, but there are big meningiomas that can be taken out and people can regain their function. So it's important that the patients at least get a good metabolic workup, make sure that there is a brain scan that is done and make sure that you get a good consultation before doing all what
Right.
you said, which is all very pertinent. And some of there is help for caregivers too. There is 211 hotline, and there are different resources within the community which you can access.
I have a question for you guys. What percentage of dementia is vascular versus like amyloid plaque versus other
Majority of it is vascular, microvascular disease
from
and breakdown.
metabolic syndrome?
And listen,
Yeah.
I don't care what part of your body, you get old enough and
Right.
you're gonna have microvascular
Right.
disease to your toes, you know what I
Right.
mean? So it breaks down, and so I think those are pertinent points. We have a question right here, and I want to get to you, and then we'll talk about the newer drugs that are coming out. And I think it's more important that we talk about the current targets and then the future targets. Go ahead.
Hi,
Hi, what is your name?
my name is Faye Eicholzer, and I got here because I live here in Acacia Village
Wonderful.
with my husband, who had a TBI from a bicycle accident in 2003.
How old was
So
he?
he was 52 at the time.
Okay.
So we've been dealing with TBI for many, many, many years.
Bicycle, riding bicycle?
Passed out while he was cycling
And
and fell right on literally on his head.
was it, he was riding fairly fast or?
No, it turns out that he passed out, and I believe the explanation later was like vasovagal syndrome. That was the best guess we've ever had.
Gotcha.
So, but more recently, and I've noticed maybe in the last year or so, signs of dementia that were different from the regular TBI stuff. And so I came here to get some information, and I'm hearing it as I'm raising my hand about care and management of dementia. He's just been diagnosed.
Do you mind talking about it? I mean,
Yeah.
when did so he had his traumatic brain injury at 55, you said 52.
Yeah.
52. And so, and then he was hospitalized.
Yeah.
Did he?
was in a coma here for.
Oh, so he was out for a
He
while.
was near death, yeah.
Oh, did they put a drain in his brain? Okay.
Ventriculostomy. I got all kinds of medical terms from all this
Wow.
stuff.
Okay, good. And so the ventriculostomy was in his head for a period of time.
Yeah.
And what's a ventricular, if I can explain it to everyone, ventriculostomy, when somebody has a bad head injury, we don't have an exam on them, right? And we talk about being in a coma. And we judged that coma based on your ability to respond. And because he wasn't able to respond very well, we had to be able to evaluate the pressure in his head so that we could make sure that enough blood got into his head to protect his brain and this area of the brain that we call a damage center and the circulating area around it called the salvageable area or the penumbra. So we put a drain in his brain and measure the pressures, and we could also drain fluid out of his brain to decrease his ICP or intracranial pressures and allow the blood pressure to get enough blood in to supply it. So, well, thank God he finally woke up and was interactive.
He was in rehab for several months, and then ongoing help as we could find it for many years.
Mhm.
Okay, so
How's he doing today?
he's possibly, I think, right now Zooming our meeting here from that. Yeah, we have talked about this a lot. Some of the things that you guys have mentioned, like using music. He plays the guitar, I do piano, we sing, we join choruses. This has been like hit and miss. They're not things that I was told medically to do. It's just we figured them out. And yes, we've done like DNRs, we've got all that kind of thing in place. But I'm at the point now, is there anything vascular, I guess is what he has, from brain injury? I'm not quite sure how it got from brain injury into dementia, but that's maybe less important to me than it's there.
Satish looks like he's ready to answer this, but he was talking about head injuries being a proponent for this.
Right. So for care, and I know I'm not looking for recovery. I don't believe that's an option or a possibility. But for management and care, medications that I don't know anything about, other than Aricept? I've never heard of any others. Is there anything a caregiver should know? Or could
So,
look out?
just want to clarify a couple of things. So when there are some conditions that predispose you to get dementia from traumatic brain injury. But one of the things that you really need to worry about is what we call as hydrocephalus, fluid buildup in the brain.
Assessor for that.
So if you have ruled that out,
Right.
that's good.
Yeah.
But there are a lot of medications that are in the horizon.
I hope that's a.
Yeah, so there are mostly Aricept that's being used, but there are a lot of other medications that are in the horizon. So and dementia and dementia related illnesses cost the country a huge number of dollars in taking care of them. So there are a lot of help available for people who need the help, and there's a lot of cost saving involved when you use a drug to help them. There are medications that are looking at energy expenditure in the brain and to change that so that the dementia gets better. There are other things that are being used, like using AI and robots to help people live through their life. So,
How would I get more information?
Yeah, listen, I'm not promoting you come to our practice, but if you want to come by, we're more than happy to kind of look at things. I think what Dr. Krishnamurthy was basically saying is that unfortunately hydrocephalus with regard to head injury and older age is not as frank or apparent. It has to be tested. So there's two things that happen is that you have a functionality of certain granulations in your brain that absorb the fluid, bring it back into a venous system, reabsorb it, and then we produce about a half a liter a day. So it can be a subtle amount that let's say your drainage system at the house is, and I know this because up at camp I had to fix it recently, right? So it's working at 90%, but it's 10% going down. Well, start today, you don't really bother you that much. Next thing you know, it's at 85, it gets down to 80. All of a sudden, you're starting to see some major problems with the plumbing system. Same thing with the brain. And it's very simple. And I know I have some students here, some medical students that 2 of them are going to medical school next year. And I tell them if they don't go into neuroscience, they can't come back and talk to me ever. So. But no, they Luke and Stephanie over there, and Haley's going to be going the year after. But they're all going to be going to medical school and doing this. But I want to tell them this and make it very simple for the brain, right? You have two major chemicals that are responding in your brain, and that's glutamate and GABA. Everything else manipulates those particular transmitters. And we do a lot of blocking the blocker in the brain, right? So everyone's like, oh my gosh, what's this doing? And the answer is that many of the things that we do from our brain is from a basal tone, right? I'm a spinal injury guy. We look at it from that standpoint. So there are targets, whether we stimulate the stimulation, block the blocker, or augment those releases in the deeper nuclei of the brain. And I know that kind of sounds complicated, but it's really just making sure that the sink faucet goes on, open up the base, and make sure you don't have any plumbing issues downstairs.
And I have some follow-up questions to that, if I might.
You like that one?
I like that one. Oh, this is all research for me.
She's gonna get on that one. I would think I should right.
So I guess my question is with regards to the new literature about the amyloid plaques. So new data are suggesting that, yes, they cause these plaques in the brain. They actually happen. That leads to Alzheimer's. But now we're starting to find that these plaques may or may not be related to development of Alzheimer's. So these drugs that you're talking about really are amyloid plaque inhibitors, if you will, which may or may not do anything. So not that I support all of RFK stuff, but let's just say in part, diet might be important. There is data that sufficiently suggests that ketogenic type diets, low carbohydrates, low sugars, can actually help with things like epilepsy, can help with brain cognitive function because you're shifting from glycolysis to fatty acid oxidation, and that might actually be beneficial for people. What do you recommend? Is that something that you recommend?
I talk too much.
Yeah, so it's a very interesting way to look at it. But as you know, amyloid, let me just introduce the topic. So in Alzheimer's dementia, there is, if you look at the brains of people who died from Alzheimer's dementia, if you cut the brain sections, there is a deposition of plaques in the chemical called amyloid that sits inside the brain, and there's some around the vessels and there's some inside the nerve cells.
The nerve cells is the one.
Nerve cells is what does everything that we are doing right now, including me speaking right now. So the amyloid has been the subject of, if you see something, that's probably what is causing it. But there are other dementing disorders that also show different kinds of chemicals, like something that Nick mentioned earlier is Lewy body disease, Hirano bodies, and all of those fancy names. These are all people who discovered different kinds of nuclear inclusions, that is inside the nerve cell nucleus that is included inside there. So whatever it is that is causing dysfunction of the nerve cell needs to go away. Now, is this because there's all these chemicals that are only coming into these particular people who are affected with this disorder? Or is there a general problem with clearing the garbage from the brain? So it's a heart of my work that I have taken up is how does brain clear garbage? And there are many different mechanisms, and people are looking at just using there are different classes of drugs for Alzheimer's form of dementia. One is to change the neurochemical balance, like what Nick was talking about, looking at GABA, looking at acetylcholine, and other neurotransmitters. That's just a neurotransmitter is a chemical that goes from one nerve to another nerve to say, hey, do this. So there is neurochemical changes. The second is look at the amyloid and say, this bad amyloid, we need to kill the amyloid and do monoclonal antibodies. It's like any infection, right? You have a virus, you give an antibody to the virus, and the virus gets killed and it goes away. It's the same logic for amyloid. Now, for amyloid, it didn't work. There are many trials that have gone on one monoclonal antibody, and it didn't work, which is what brings us to this question as to what is causing the problem. And there is a third component, which is the energy expenditure, which is what I was talking about. And there was a recent article looking at, so the brain needs glucose. Brain needs only two things, oxygen and glucose, and definitely not doom scrolling. So the brain consumes the oxygen and uses the glucose, breaks down the glucose to form what is called as cellular energy currency. It's stored in as ATP or NAD. And in amyloid disease, NAD plus, which is the currency, energy currency, is lower for normal activities. So there are multiple ways that they're looking at it. One is to improve the currency, to improve the energy state of the cell so that the energy goes into performing cognitive tasks. There are some good results in a mice study. And the second is we are trying to export the amyloid out and make it go away from the cells. It doesn't matter whether it's amyloid or some other our brains have the machinery to get rid of the garbage. So if you clear the garbage, the nerve cell will go back to working normally.
So you
So
have a question? Oh, okay. I was just, yeah, we'll get to your question one second. Why don't you stand up? So, and remember, so I think this is where he's coming back to is, Alzheimer's. When we're talking about Alzheimer's amyloidosis, location of the brain where that particular breakdown occurs is obviously in the frontal lobe and those locus. Go ahead, your question.
I just wanted to let you guys know we have about 10 minutes left, so we'll take another question and then I'll still give everybody time for a tour if you'd like.
Okay.
Yeah,
Sorry.
in terms of
good explanation. Go ahead.
the energy currency that the brain is using, the NAD and the ATP, I know there's been studies into creatine, high dosages of creatine to combat sleep deprivation. Could you please comment on that? Elaborate any studies you've read on creatine?
I think the study was done. It showed,
Mostly muscle,
yeah.
skeletal muscle. It helps with bodybuilding.
So you got
No,
to
but
be
it-
careful with the creatine
protective.
input. Creatine input, right? So there is something called a Krebs cycle that makes most of the fats, carbohydrates and proteins, no matter what you eat, except for vitamins, essential fatty acid, and essential amino acids. These are three things that the body cannot manufacture, but Krebs cycle takes care of all of this. So if you're worried about creatine and muscle building, think of an elephant. It eats only grass, and it's got more muscles in its trunk than the entire human body. So the creatine, if you take a lot of it, will kill your kidneys before it builds anything else. So
most people are taking creatine are also working out. So was it chicken, egg, or both? I think I take it.
No,
I'll take anything.
You have more ATP, so therefore you get buildup of NAD plus naturally. So, but it is bad for your kidneys, as is all protein-rich diets.
yeah, like the recent study about creatine and sleep deprived people. I don't remember off the top of my head the title of the research article, but they kind of looked in people who had maybe night shifts, and they gave it a 20-gram dosage of creatine,
Yeah, it
and
was
they
20.
found
It was 20 milligrams. Yeah.
Yeah.
20 grams.
20.
Anyway.
And they found that they slept better?
No, it was protected. It was neuroprotective. And I forgot the endpoints that they were using in order to check it. Yeah, you notice I don't even need a microphone. I'm so loud. But I forgot the endpoints that they were checking for it. But when I read it, it was a while back. I bought a bunch of creatine because it made sense. And it's the soluble creatine because there's two types. And I bought some soluble stuff that was pretty good. Don't laugh, Luke. You know I put it in my shakes.
I thought you were gonna ask about intermittent fasting with brain cleanup of junk.
And that's what I was gonna get to, but we don't have
Yeah,
time.
we don't
But
have time.
you know,
We can take a
the
couple
scavenger macrophages for that is very protected neurocognitively, and I've gotten to 96 hours.
That would be
Yeah.
the same as a
A wet
ketogenic
fast.
diet,
Wet fast.
essentially.
Flat fast, meaning that she's trying to indicate that I drink a boatload of coffee. It's
Yeah.
true. It's true. No gum. I haven't done gum.
But yeah, I think
Well,
that's the frontier is the fasting situation and Mediterranean diet and fasting. We know on a pure linear line, the less you eat as a human, the longer you will live.
I think you
Period.
should-
End of story.
Honestly, I think what Maria is doing with these discussions, I see Reed back there. See, Reed's brilliant. He's very much on. I mean, everybody wants to see Reed because his physique is like perfect.
Lots
and,
of creatine.
yeah, lots of creatine. But he's one of my PAs. He's brilliant. He's a great guy. A couple things real quick. Number one, this is amazing that you're doing this, and I support you on this. But I think this is going to build into something even bigger. I would put this on one of those things that everybody scrolls through, so they can scroll through and carry. Thanks for Blue Cross Blue Shield support on this as well. And I love this. I'm gonna come to every one that you have, and honestly, I hope this builds into something bigger and maybe even roundtables and bigger conferences like we were looking to do in the future. Thank you so much for doing this.
Thank you.
And
Thank you, guys.
really an expert.
And Liz? To say thank you to the audience, in particular our sponsors, which is CNY Neuroscience and Neurosurgery, and also the Mohawk Valley Living magazine. So we thank you guys for your great support. And thank you to the audience and those who are on Zoom who are able to follow us today. I hope you tell all your friends about what we're doing here. We're trying to connect the community, inform the community, and we're open here anytime if you have questions. We'll connect you with people we know.